What are your steps for a vacuum-assisted vaginal delivery?
Uh, First, I would assess the fetal station. I want to make sure the fetal station is +2 or more. Then I would palpate the fetal head to make sure I know um, the position of the baby. Um, and then also I want to make sure I know where the posterior and anterior fontanelles are and where the sagittal sutures are. After all that, I will place the kiwi vacuum um, two, uh, 2 centimeters anterior to the posterior fontanelle along the sagittal suture. And then with maternal pushing, I will also apply gentle traction on the fetal head.
Okay. Uh, what are the risks for a vacuum delivery?
The risk of vacuum delivery mainly pertains to the fetal head, which includes uh, uh, cephalohematoma, subgaleal hematoma, hemorrhage. Um, uh, it could be also subarachnoid hematoma or hemorrhage. There could be scalp lacerations or um, retinal hemorrhages as well.
Which is okay, which is the worst station of those options?
Um, sub Subdural hematoma will probably be the worst. However, it's much rare. The next one will be subgaleal hematoma or hemorrhage. Um, and then um, the subfloor hematoma will be the most common and least dangerous.
Okay. Um, do you do forceps delivery?
Um, I don't routinely do forceps deliveries.
What would be the benefit of being able to do a forcep delivery? When or what would be the indication to doing one?
Um, as opposed to vacuum delivery.
Yes.
For a forceps delivery, the uh, the chance of success is higher, um, and also I think that's um, the main reason you would choose a forceps over a vacuum.
Okay. What have they seen in comparison to in terms of neonatal outcome between a C-section and forcep?
Uh, in terms of neonatal outcome,
Yes.
um, I would say the forceps deliveries has higher chance of fetal scalp laceration and uh, retinal hemorrhages. Um, and that's the two I could think of, or
Okay.
maybe even a scalp deformation from a forceps.
Okay. Um, all right. And then moving on, if I could get back over to that tab. Um, For your patient number 15, what's your hospital's massive transfusion protocol?
Um, the massive transfusion protocol at my hospital includes six 4 units of packed red blood cell with 4 units of FFP. Um, and then they will continue to bring you blood products until you tell them to stop.
Okay. Do you know what the recommended blood component replacement therapy is?
The recommended is 1 to 1 to 1, 1 unit of packed red blood cell, 1 FFP, and 1 platelet.
Okay. With a massive transfusion, if you were to replace 6 units of packed red blood cells, what else would you want to consider checking or replacing?
I would want to replace the um, clotting factors. So I would definitely want to give this patient FFP or cryo to
Hmm.
replace at least the fibrinogens. And then I will also consider giving this patient platelets as well.
Okay. Is there anything else in terms of electrolytes that you have to worry about?
Patient can also develop hypocalcemia, so I would consider giving calcium gluconate with each unit.
With each unit?
With yes, but I don't
Okay.
remember the dosing.
Okay. All right. And then I write down all the questions. Then I have to find them because I lose them. This patient is also a grand multip. What are the risks for pregnancy in terms of grand multiparity?
Uh, Precipitous delivery, postpartum hemorrhage, uh, um, uh, prolonged gestation. Uh, I think that's all I can think of.
All right. Are there any steps that you take given these risks on labor and delivery for these patients?
For her, I would have the hemorrhage cart uh ready and available in the room.
Oh,
And however, because of the low chance of them actually needing, actually having a postpartum hemorrhage, I do not routinely give prophylactic doses.
okay. Uh, what would be what would be your indication to administer TXA?
I have a low threshold for giving TXA. It will probably be the first agent I will give if I encounter postpartum hemorrhage um, along with Pitocin. Um, if the patient is at higher risk for postpartum hemorrhage, I do consider giving prophylactic TXA um, uh, during like maybe a C-section. I will give it prior to skin incision.
Okay. When what what amount of time? Hold on, let me. In what amount
Three
of time?
hours.
Okay, great, thanks. I couldn't figure out. Did they find a decrease in mortality?
Oh, that's a good question. I would think the amount of it maybe decrease the blood loss. I'm not sure about the decreased mortality.
Okay. All right. And then for your patient who declined a tolac, what's the general success rate for tolac, or what are the factors that can contribute to it?
Uh, decreased or increased chance?
What are positive predictors?
Oh, okay. So for TOLAC, usually I counsel the patient that there's the success rate is around 60 to 80%, depending on their individual factors. Some of the positive factors will include prior vaginal delivery, prior successful VBAC, um,
Is
patient
it is it only a VBAC or if it's any vaginal delivery?
any vaginal deliveries as well.
Okay.
And also, if the patient comes in labor, um, um, the fetus is less than 4,000 grams or is not macrosomic, patient is not obese. Um, that's all I can think of right now.
Cool. All right. And I wonder if they're going to ask us about race with Tolac. They took
Hmm.
race out of the calculator.
Race was on there?
Yeah,
Oh, I
they
don't
took it
know.
off.
They
Yeah.
took it off.
Yeah.
Okay,
They
so
took it
it's
off
not.
like, yeah, they took it off like 2 months ago.
Oh, the one
Yeah.
the maternal fetal medicine one? Is that the one you're talking about?
Yeah.
Oh, okay.
So, yeah. What would be the Bishop score that would help you? This is not on any of the patients generally.
Okay.
Which Bishop score would be a positive predictor for an induction?
Uh, so a Bishop score greater than 8 means that you have the success rate of someone coming in active labor. So greater than 8.
If their cervix was less than 6, the Bishop score, uh, how would you counsel them on induction?
If it's less than 6, I would tell or I would discuss with them that they might need some sort of cervical ripening agent, either um, a prostaglandin such as cytotec or Cervidil, or a mechanical um, dilator with the Pitocin.
Okay, great. Do I have anything else written down? Your patient, I can't remember. I've already asked this.
That's fine. You can always ask. Never hurt
Yeah.
to practice.
Patient 26, when would you consider starting a non-stress test for this patient?
This patient has gestational hypertension and GDMA. I would start the patient on antenatal testing at 32 weeks.
Okay, when was she diagnosed with gestational hypertension?
She was diagnosed with gestational hypertension at 20 around 28 weeks.
Why was she still pregnant at 38 weeks?
Oh, oh,
Go lie.
oh, you mean just, oh, hypertension. I'm sorry.
Oh, okay.
Hypertension, she was diagnosed just recently at 28 weeks. And then,
30.
oh, I mean, yeah, 38 weeks. Oh, I thought you meant like gestation,
Yeah.
diabetes. Sorry.
All right. No, 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 that's fine. I was like, oh no, they will.
So,
Um, all right. Cool. Um, so yes, I think for 26, you could say, patient, given her risk factors of AMA at age 40 with GDM, we started antenatal testing at 32 weeks, even though she's not, GDMA2, given her risk factors. You don't
oh,
have it on
uh-huh.
your management. I think so. What their thing is it just says individualize.
For GDM?
No, for
Oh,
GDMA1, they
for
don't even,
AMA.
but for AMA and GDMA1, they don't need it. So it'd be a combo of the risk factors because that's their whole thing with AMA and antenatal testing.
So there is a ACOG article. I don't remember what type of.
If you pull it up, it literally says individualized.
No, no, on the antenatal one, yes. But if you read the AMA article, there's let me find it real quick. Cause I have like a summary of it. If it's a if they're over 40, so NST is not recommended for 35 to 40. However, antenatal surveillance is should be offered um, for someone who's 40 plus.
But that's like grade C data.
I mean, if they recommend it, it doesn't matter what data is. I'm gonna say I do it just because they mentioned it. So growth ultrasound at third,
36.
yeah, after third in the third trimester, and then because the antenatal surveillance should be offered if the risk of stillbirth is greater than zero point 0.8 out of 1,000.
Yeah.
Um, and if you're at 40 years old, the risk of you having a stillbirth is
It's like a
like
26
one
year old
one
and
it's almost like 1%. Yeah.
that's why
So
it's induction 39 to 39 and 6. Um, but they don't say when to start antenatal
yeah.
or antenatal testing.
So I would just do 32. That's because that's the most common.
32
Um,
and 34. I think that's fine. I would just like if they were like if they asked you, then I would just say given AMA multi-parity GDM.
yeah, yeah.
Like, you know what I mean? Like
Mm-hmm. No,
I
no.
don't
I understand. Um,
if they even
but
care.
yeah, you can always say like there's no strong recommendation, but I would do this because this, you know. I
Yeah,
would I
that's
would
I'm
I would start them on antenatal testing because they are at a higher increased risk for stillbirth. So therefore, you know.
yeah. Yeah, I have a bunch of patients that I think are 40 years old or more and they're still pregnant at like 40 weeks.
Oh,
And it's
yeah.
like, yeah, well, my group won't even induce gestational hypertension, so I'm just struggling against the tide here, okay?
That's crazy.
Dude, oh my, and I don't know how much you talked to Cecilia, but they are being effing insane to her, and it's so crazy because this group was like such a wonderful, like, fine, maybe a little outdated, but like all for one, one for all. And now I'm like, oh my God, like you guys are maybe insane.
Because she's leaving?
Yeah, they're being so mean to her.
Yeah, I can see that happening.
Oh, poor,
Oh well,
oh,
she'll be leaving soon. Doesn't matter.
I know, but poor Cecilia. I'm like, don't be mean to my chief. Even if I was terrified of her as an intern, don't be mean to her.
So, all right,
Yeah,
you want to do yours?
yeah, everything, hold on. Everything you said about Tolac was
Oh yeah,
right.
we haven't gone through everything.
And then, where did my little note thing go?
Tolac. Did I miss anything?
No, I think you got it. And yeah, same perfect answer for bishop score of 6 and 8. All of that was perfect. Um, Same for your massive transfusion. For steps for vacuum, I think you just missed emptying bladder.
Oh, okay.
And may want to just like know what millimeter mercury you
500.
yeah, same. But yeah, but just if I don't know if they would say that.
They might, because they're assholes.
And you have to, I don't know if they want it or if it would just be like a feather in your cap to be like, and discussion that if this failed, the next step would be to proceed with cesarean. Um,
Mm.
and like the ability to do so.
The ability
And
what?
then the ability to convert to a C-section.
Oh yeah,
Like,
yeah. The okay.
um, yeah, and I don't know, like for me, I don't have like a backup necessarily, like shit like that. Um, and then for forceps, it's rotational.
Oh, they can do rotational, correct.
Oh, if it was like so asynclitic, it's better for vacuum because you can place a vacuum on an
Right.
asynclitic
Yeah, I was thinking
presentation.
about asynclitic, but then I was like, that's for vacuum, so
Technically, vacuums are supposed to be OA. I don't think any single one of us doesn't place it if it's slightly LOA or ROA or like
I mean,
OP.
sometimes I don't even know if they're OP or OA. I would still put it on there
Dude,
because
I don't even know the sagittal suture. Like, yeah, I'm just like, well, pretty sure I'm not on the
yeah,
posterior front. No,
right.
here though.
As long as not on the mom, that's fine.
Um, exactly. Like, well, they're gonna come or it won't. And but yeah, so that's one of the benefits of the forceps. And then I don't
So
know if they would ask us to name any. I do you remember which ones? Was it Tucker or something that we used to use?
Tucker McLean. I
Oh,
mean, you
yeah.
don't if you don't use
Okay.
forcep, I doubt they will ask you anything about or too much about it.
Yeah, I just think that they ask like, what's the benefit of it? What's the risk of it? It's like a general.
Right.
It's the same as them asking us about vaginal delivery or vaginal hysterectomy, which I actually have one tomorrow.
Vaginal hysterectomy. Oh, TVH.
Yeah, it's like what I mean. Like none of us really do them, and yet we still have to know them.
Right.
Um. All right. Cool.
Oh, let's go over the transfusion stuff.
Sure.
Because you were mentioning something about the calcium. That's the one I
Mortality.
did. I'm sorry?
TX. Oh yeah. Okay. So first, TXA lowers mortality. It does not lower morbidity.
Okay. Interesting.
So anyway, that's a good thing to know. And then
What about
uh
the calcium?
calcium, you don't have to do it with I don't know that you actually have to if there's like a rule of how many um units, but that you could say okay, so it's 1 gram of calcium with the first unit and then after every 4 units.
Oh, okay.
So it's not one per unit, but you could say once when I know that I will be transfusing, I provide 1 gram of calcium. Then I repeat it after another 4 units of packed red blood cells.
For you guys, for the massive transfusion protocol, do they give you platelets?
Dude, did I not tell you about the time that we didn't even have platelets in the hospital and we had to get them from the
Uh,
fucking Red
oh yeah,
Cross?
yeah, yeah, you did.
Yeah, no. So um, I had two different hemorrhages over the weekend, which is why I know the calcium thing. Because one patient had 3.5 liters of blood in her abdomen after a ruptured ectopic.
Mm,
The other
Jesus.
one was high on meth and had left Pomona Valley, AMA, after getting transfused from 4 to 6, being diagnosed with preterm labor and preeclampsia, and she decided to grace us with her presence.
Mm.
That was cool. But so our massive transfusion protocol is 411. So it's four of packed red blood, one of FFP, one of platelets, but the platelets are like miss, and that's if they even give us the blood. Like I've activated the massive transfusion protocol so many times and they're just like, nah. And you're like, please send me blood, and they're like, not gonna do that.
That's crazy.
Um, but yeah, my anesthesiologist, one of the anesthesiologists that I had was an idiot, and
Yeah, you told me about
he
that.
well, yeah, no, this is from this last. Oh, did I say from this last weekend? But this he doesn't check their calcium, so I have to do it, which is like really fucking annoying. Like,
Do everything.
don't.
All right, right. Okay, so let's move on. 20. Okay, 24. 24, you have a patient with low apgars. What happened with this one?
So this patient's a 26-year-old G1 who presented with pre-labor rupture membranes. We induced her labor with pitocin, or excuse me, with oxytocin, and she had an uncomplicated delivery with a reassuring strip. However, she was at patient was at +5 station for several minutes. And when baby came out, showed decreased fetal tone and respiratory effort, we called the and while we were waiting for the respiratory therapy team, the neonatal nurse was still training. And I did not notice it initially, but she was actually covering the neonate's nose and mouth with the rubber of the mask and occluding its ability to breathe.
Oh,
At
okay.
which point I showed her the correct positioning. They continued breathing. I asked for the charge nurse, and the respiratory therapy team arrived. At which point, baby recovered.
Okay. So how do you calculate an apgar score? What are the
apgar scores
components?
have 5 different portions: appearance, pulse, grimace, um, my God, respiratory rate, excuse me, activity, and it is based on their color, heart rate, their effort, and whether their muscle tone.
Okay,
So, and
not bad.
is panicking, if I can come back to that in 1 second, and reflexes.
All right. Okay, no more laughing. Okay, we're serious.
Tired.
All right. Okay, 20 patient 29. Um,
Mhm.
so what is considered a suboptimal dating ultrasound? At what gestational age?
Optimal dating is performed in the first trimester,
No,
where you can,
suboptimal.
I
Suboptimal.
know, but yeah, but you can direct the
Okay,
question.
all right, go ahead.
Optimal dating is the first trimester if it is within 5 days of the first day of the last menstrual period. If it is under 10 days, excuse me, under 5 days difference under week 10, and under 7 days different under week 14, which is the best option for optimal gestational age dating. In the third trimester, because it is ±3 weeks from the known last menstrual period, that makes it difficult to assess a uh, optimal gestational age.
Okay. So for this patient, your dating was based on the gestational age? I mean, the ultrasound?
This was Yes, where she presented in labor, we then performed an ultrasound to get an estimate of the fetal gestational age. However, we did notify the NICU secondary to the risk for possible prematurity with undiagnosed gestational diabetes.
Okay, so let's say you have a patient with suboptimally dated ultrasound. Um, how would you, when would you uh, and when would you induce this patient, or you wouldn't?
I would not induce this patient. However, if we had 20 weeks from fetal motion or over 26 weeks of being able to auscultate fetal heart rate through with an external fetal Doppler, or if the ultrasound was in accordance with known last menstrual period.
Okay. All right, let's move on. Patient 40. So this patient had a low-lying placenta. Let's just say this patient had a previa. When would you deliver a patient with previa?
Patient with previa, we would deliver between 37 and 38 weeks via C-section.
Okay, so this patient would have, so you would did, okay. What about a Creta?
We would deliver between 36. Well, truly in our practice, we would have transferred her to a higher level of care. However, a patient with a CRETA should be delivered at 36 weeks,
Okay.
36 to 37 and 6.
Patient 44. This patient had NIPT, is NIPT positive. What is the positive predictive value for a positive NIPT for trisomy 21?
NIPT has a 95% detection rate for trisomy 21.
Okay. You said detection rate. That's sensitivity, right?
It's the it has a 95% positive predictive value.
Okay. So for everybody.
For trisomy 21.
Right, right, right. But for any individual.
I believe that it is 95% for patients 35 and older, and it has a decreasing positive predictive value as the patient age decreases, though I am not able to recall the exact percentage.
Okay. So did this patient actually had or not the patient, but did the fetus actually had Down syndrome?
The fetus had Down syndrome appearing facies. However, after discharge from the hospital, at which time they were going to do karyotype, I was unable to obtain the results.
Okay. And then on the ultrasound, was there any findings that would be suspicious for trisomy 21?
This patient did have soft markers for trisomy 21 on the anatomy scan, which included a double bubble and an echocardiogenic focus.
What is a double bubble?
The stomach bubble and the duodenum.
Okay. I don't know either. That's why I asked you.
Like double bubble
Isn't
ultrasound.
that duodenal atresia when they have a double bubble sign?
Yep.
Okay. All right.
Yes, that
Patient 45. So this patient, oh, that's weird. I want to ask you something about choreo, apparently, but this patient doesn't have choreo.
that's okay.
Um, what's the risk for the neonate if the patient had a had choreo?
If the Patient has core infection, fever, admission to the NICU, for neonatal sepsis.
Say that again. I got cut. You got cut out. Sorry.
Sorry. The risk to the neonate is infection, fever, admission to the NICU, neonatal sepsis.
Okay. Uh, 56. 56. This patient had IVF with pre-implantation genetic testing. Um, so how would you counsel this patient about her prenatal genetic screening?
So for this patient with pre-implantation genetic testing, it is able to check the embryo. Um, Depending on different types of pre-implantation genetic testing, they could have tested the egg and the sperm. They could have tested the embryo in a blastocyst stage. The for the prenatal testing, I counsel that the implantation genetic testing is not able to detect any abnormalities of, oh my God, what is this called? Disjunction or chromosomal replication, at which time NIPT would be an appropriate screening option if they wanted to pursue it.
Okay. Patient 60. 60. So this patient had late-term pregnancy. Is there something that you do differently for someone who had late-term pregnancy?
For our practice, we induce at 41 weeks. However, a patient, if they are to decline induction and prefer to wait until post-term at 42 weeks, we would recommend NST with modified BPP, so an NST with AFI twice a week.
Okay. So what's the risk of a
However,
huh?
that's a good go for. All of our patients we induce at 41 weeks, so it is a matter of whether or not they are having a 3-day induction, uh, and which time, of course, they are continuously monitored.
What's the risk of a post-term pregnancy?
Risk for postpartum pregnancy is meconium aspiration, risk for C-section, large for gestational age, further risk for lacerations, um, stillbirth.
What's the last one?
Stillbirth.
Oh, okay. 62. This patient has a two-vessel cord. How do you counsel this patient? Well, first of all, um, which normally do you have? Which two cords do you have? Or which three vessels do you have?
There should be 2 umbilical arteries and 1 umbilical vein.
Okay. And then for this patient who has only two vessel cord, how do you counsel this patient about that?
There can be a risk for, or has been associated with low birth weight, fetal and cardiac and renal anomalies. Um, there is no extra evaluation for aneuploidy besides NIPT. However, we will generally begin weekly antenatal surveillance at 36 weeks.
Okay. And would you deliver this patient early?
Not unless there was a risk, not unless there was growth restriction, or poor antenatal testing.
Okay. Does two vessel cord cause growth restriction?
It has been associated with, but not necessarily caused.
Okay.
Oh, we might actually induce them at 40 weeks. I don't remember.
60, 66. So this patient had a EFW of 4,000 at 37 weeks. How did you counsel her about that?
This patient was scheduled by my colleague. However, at 37 weeks, for all of our patients, we perform a 36-week growth scan to confirm size and position. This patient was found to have an estimated fetal weight of 4,000. Given that they gain approximately 250 grams per week, the patient was counseled on our option for continuing pregnancy, waiting for spontaneous labor versus induction at 39 weeks, given the ARRIVE trial, which showed that it could have a possibly decreased risk for C-section. The patient elected for an induction of labor.
Okay. Um, and then at 39 weeks, this fetus only weighed 3,700 grams. Okay.
The
Patient,
margin of a full-term ultrasound at 36 weeks is plus or minus a pound. And looks like that's what we were in.
patient 74. So this patient had anti-cal antibody. Um, how do you manage that?
So this patient with her initial type and screen was found to be anti-cal positive with titers of 1 to 2. So for this patient, she had an MFM consultation, serial growth scans, serial Dopplers. We would monitor the um, titers. However, we counseled that the titers are not associated with severity of impact to fetal well-being. And we also recommended partner testing as the patient did have a history of postpartum hemorrhage and transfusion. However, to determine if there would be possibility of exposure through prior pregnancy. However, the partner did not perform partner testing.
So how did you manage this pregnancy? You said antenatal testing.
So yeah, so this patient had antenatal testing and surveillance and recommended induction by MFM at 37 weeks and underwent an uncomplicated delivery. Given my hospital's difficulty with providing blood component therapy, I did provide prophylactic extrauterine tonics and TXA given her history of hemorrhage.
What antenatal testing did you do?
This patient received twice weekly NSTs as well as middle cerebral artery Dopplers, assessed for fetal anemia.
Okay, and then um what's a positive CMA Doppler for anemia?
I would have to look that up.
Okay. Let's say this patient doesn't have anti-K but anti-D. And you said that titer didn't affect the management. What about anti-D? Would the titer affect management for anti-D?
Anti-D, the titer does affect management. However, I would also request for the non-invasive prenatal testing that is able to assess for fetal blood type or fetal RH status.
Okay. But you wouldn't do that for anti-cal?
There is no NIPT that is able to assess for Cal status. It's only via amniocentesis.
Oh, you mean just an NIPT to test for
Yeah.
anti-D. Got it. So you said the titer does matter. So what is a um, so what's a bad number, and what's not a bad number?
I believe a fourfold increase, but I would have to double check.
Okay. All right.
One in eight is a bad number, and less than 1 in 8 is not a bad number.
Okay. Um, 90, 92. Last question. Um, this patient has hypothyroidism. How do you manage hypothyroidism in pregnancy?
So for hypothyroidism, if it has been previously diagnosed, then we check for TSH and T4 with the goal of TSH between 2.5 in the first, second, and third trimester, though some data says you could do TSH under 3 in the second trimester. The We then prescribe continue levothyroxine, given if whether determined whether she was already on it or if we are initiating. We also co-manage with maternal fetal medicine as well as endocrinology to ensure that she will have proper management during and then thereafter the pregnancy. If her thyroid function status, if her thyroid status is normal, then we are not as concerned for the neonate. However, we do recommend induction at 40 weeks if they have positive thyroid antibodies.
Okay. All right, let's go over it. Let me see, 2024, right? Apgars. I think you got them, right? Reflex. That's the one that you almost forgot.
Yeah.
Yeah.
It's
So,
weird that, like, when your brain just won't absorb something, it's been that. Like, my
yeah.
brain is always like, nah, I'm not going to do that one.
It's like I don't care about Apgars at all. Like,
Yeah.
I know.
Like, shit.
But you have it on there, they might ask you.
I
So,
know. I know they definitely will. And I like don't even know if I should tell the truth about that one. Like it's ridiculous. It's literally an incompetent nurse like was blocking the doorway.
yeah, well, 29, suboptimal dating is any ultrasound not done before 22 weeks. So if the,
Okay.
yeah. So, and if you have a suboptimally dated pregnancy, you're supposed to if and you want to induce them, you have to wait till 41 weeks to induce because you don't know.
Mhm.
And then
Yeah.
you're supposed to do antenatal surveillance starting at 39 weeks. Um, and also you can repeat the ultrasound in 2 to 4 weeks to make sure that the patient doesn't have it's not developing IUGR because you don't know if the baby is small for that whatever the age they're supposed to be, but you can track the growth curve, right, to see if they have IUGR that way.
Mhm.
Um, and then I know you're trying to say those four criterias. I think it's 36 weeks of here having a doptone,
Yeah.
and then no 30 weeks of hearing doptone, and then 36 weeks of having a positive pregnancy test. So that makes you 40, right? 36
Yeah.
plus 4 weeks, that makes you 40. And then like the ultrasound, the LMP, the ultrasound, um, before
There's one
22
that's
weeks.
movement.
Yeah, 20 weeks, feeling the movement at 20 weeks. For 20 weeks of movement, that one too. Um, and then we talked about Previa. So Previa is actually 36 to 37, so you can deliver at 36 weeks. And
Yeah.
then Acrita, I think it's 34. It's usually 2 weeks before. Am I right?
Yeah, let me double check that.
Yeah.
Yeah. They like changed some of the timing for some of these things. That's why it's like throwing me off.
Yeah. Akrita is, yeah, 34 and then previous
Yeah,
36.
yeah,
Uh,
34 to 35 and 6.
yeah. And
Um,
then the NIPT, you said that correctly, it's 95 ppv, positive predictive value. And then uh, for someone who's less than 35, it's actually 85% for a low risk patient. Um,
mhm.
and and the detection rate, which is the same as sensitivity, is actually like 99.5%. So it's like really high. Um, and then,
Negative predictive value?
I'm sorry?
Sensitivity. The sensitivity is 99?
Yeah, so the detection rate, which is the
Okay.
same as sensitivity. Yeah.
Yeah.
So what's the chance of the test picking it up if the patient has Down
Yes.
syndrome? And then
2%.
that's like 99%. But what's the chance of the patient having the disease if the test is positive, which is the positive predictive value, and that's 95% for a high risk
35.
patient. Yeah.
Okay. Cool.
And then choreo, what did I ask you about choreo? The neonatal risk.
Yeah, risk to neonate.
So, yeah, so sepsis, I think like pneumonia, increased chance, and NICU admission, and I think that's, yeah. Um, and then the pre-implantation genetic testing, you said that correctly. You're supposed to still offer all the normal NIPT and all that stuff. It doesn't change anything, basically. And then 60, what was 60? Let me see. Patient 60.
Oh, late term, how would you manage?
Oh yeah, yeah. Post term. Um, yeah, you're supposed to start doing antenatal surveillance at 41 weeks with NST, twice weekly, and then recommend delivery at 42 weeks.
Yeah.
Um, and then the risk, you said it. Um, and 62, the 2-vessel core, patients at increased risk for structural abnormalities. They're actually not at increased risk for aneuploidies. I think you said that correctly. And then also, I don't think you do anything differently. I don't know about the induction at 40. That I'm not sure.
No, I think I can't remember for this. I don't know either. I didn't see it. I'll look for it, but I don't think that we do. I think we're just like, all right, like everything else was normal. We do a 36-week scan and then we're good.
Yeah.
You're just
Yeah.
monitoring for growth
So you
restriction.
just basically encourage the having a detailed anatomy ultrasound. If everything on the ultrasound looks normal, then that's it.
Yeah.
Patients should be fine. And then the 4K at 37 weeks. That's some crazy bad ultrasound, by the way.
Yeah, you're telling me.
Um, anyways. So yeah, so you just have to talk about the score the error, 20% error for the ultrasound. So um that's what I was trying to get at. Anti-cal, uh what you said was correct, and then anti-D is actually 1 to 16 is the cutoff. So 1 to 8 is
Mhm.
normal. Well, not normal, it's not bad. And then 1 to 16 is when you are supposed to start surveillance with a MCA Doppler. And then the MCA is abnormal at 1.5 multiples of mean MOM.
Nice. All right.
Yeah. And then hypothyroid. So for hypothyroid, you follow the TSH. And then it's supposed to be less than 2.5.
Yeah. The I mean